This learning object is a production of Abu Dhabi Men's College, Center of Excellence for ICT and Learning Technology.
The major problem in heart failure is increased intracardiac pressure. That increased intracardiac pressure, let's divide the heart into two parts and let's study the effects of increased intracardiac pressure on each side of the heart. Let's start by the right side of the heart. If the intracardiac pressure increases in the right side of the heart, what basically is going to do is, as I said, the ejection fraction or the cardiac output has now decreased. Since it has decreased, which means that the residual volume inside the right ventricle has increased. So the movement or the propelling of blood from the right atrium to the right ventricle is decreasing, because as we know that the movement of blood from the upper part of the heart to the lower part of the heart depends on the pressure difference between the right atrium and the right ventricle. Now the difference has lessened or has decreased. There won't be much movement of blood from the right atrium to the right ventricle. So what will happen basically is the venous return to the right atrium through the superior and inferior vena cava would not be as effective as it used to be, because now the atrium is full of blood. So basically the blood that is drained from the superior and inferior vena cava will be hindered and will be stagnating and accumulating in the tissues, because as we know these two superior veins drain blood from almost all the tissues in the body. Let's start with the head, for example. A patient with right-sided heart failure, the blood would accumulate in the head and neck, and consequently the patient would have distended neck veins due to the accumulation of or the pooling of blood in these veins. If we go a little bit lower, let's talk about the abdomen, for example. If the blood cannot be drained from the liver and the spleen, these two tissues would be engorged and congested with the blood, and consequently the patient would have hepatomegaly and splenomegaly. If we talk about the intestines and the stomach, they would also be engorged and congested with the blood, and consequently the patient would have nausea and vomiting. This is primarily on the right side of the heart. If I go a little bit lower to the lower extremities, because blood cannot be drained from the lower extremities, the patient would have what we call edema. All the blood would accumulate in the lower extremities, and the patient would have lower limb edema. On the other hand, on the left side of the heart, the same pathophysiology applies, where, as I said, when the cardiac output decreases, the blood, the residual volume in the left ventricle would increase, and consequently the pressure difference between the left atrium and the left ventricle would decrease, and then the communication or the movement of blood between the left atrium and the left ventricle would be hindered. Consequently, the blood will accumulate in the left atrium. But we have to keep in mind that into the left atrium, I have 4 pulmonary veins draining, coming from the left and right lung. So basically, if the left atrium is full, the blood cannot drain to the left atrium, and blood would stay and engorge the pulmonary capillaries. And keep in mind that blood is maintained within the blood vessels due to a pressure known as oncotic pressure that is affected primarily by albumin. This oncotic pressure is always opposed by another pressure, that is the hydrostatic pressure of fluid inside the blood vessel. Now, as I said, if, the vessels are being congested with fluids due to the pooling of blood inside these vessels, which means that the hydrostatic pressure is increasing. The hydrostatic pressure would increase gradually up to an extent that it will overcome or it will beat the oncotic pressure. If we reach to that stage, fluid would escape from the pulmonary capillaries into the pulmonary tissue, and it will basically sink the pulmonary tissue. It will pool in the pulmonary tissue, and if that happens, that means the diffusion of gases in the pulmonary tissues will be hindered, will not take place anymore, and the patient would literally sink in his secretions. As a symptom that we see, if you auscultate the patients with pulmonary congestion or pulmonary edema, his lungs would be crackling due to the movement of air within the fluid. It's very characteristic lung sound, which we call crackling. The patient would also have a very characteristic sputum, which we call frothy sputum. It's a sputum that is frothy due to the presence of extra fluid inside the pulmonary beds. Well, The treatment we want to talk about today is digoxin. Digoxin is the drug of choice for to potentiate or to maximize the cardiac output. As we all know that digoxin is an inotropic medication. Inotropic positive means a medication that increases the contractility of the heart. But we also have to keep in mind that digoxin is chronotropic negative and dromotropic negative. Chronotropic negative means that I expect a patient who is on digoxin to have decreased heart rate. Dromotropic negative means that I expect a patient on digoxin to have possible conduction defects later on, or PR prolongation. So if somebody is on digoxin and you run an ECG on that patient, okay, you might see the digoxin effect, which is bradycardia and possible prolonged PR interval. And a characteristic sign on ECG would be what we call digoxin sign, or the Salvador Dali sign, where you have a saddle-like T wave. Well, if a patient was to be started in digoxin, we need to run a battle of studies, namely electrolytes, specifically calcium and potassium, because for digoxin to work effectively, these two electrolytes, calcium and potassium, must be within normal range. And we have to keep in mind that that digoxin has very narrow therapeutic index, which means that a patient who's receiving digoxin might get digoxin toxicity even with a minor increase in his dose if his kidneys are not metabolizing digoxin efficiently and properly. And even if his potassium level is not up to normal or his calcium level is altered. So keep that in mind. Digoxin, the patient must be taught about the possible medications that might affect digoxin as well. The patient underlying cause of heart failure must be discussed. For example, if the cause of heart failure was chronic hypertension, the patient must be started on an antihypertensive medication, and so on and so forth. Thank you very much.